Hello, Elise.
Tim, I'm going to stop screen sharing so you can pull up your screen and I can get to the chat.
Okay, thank you. And how do I say your name correctly?
You're muted right now. I can't hear you.
I don't seem to be muted, but maybe I am. Can you not hear me?
Well, I can hear you now. So
Okay. I was gonna say, I thought I wasn't muted. I'll say, how do you pronounce your first name?
Odalise.
Okay, so I just wanted to make sure I was saying it correctly because I hate to keep saying it wrong. So I appreciate that. So share screen. Let's go to this one. Now, if I switch it, is that correct now? We hope. Perfect. I'm just going to say everybody can see that, I hope. That's good. Elise, how are you doing today?
I'm doing very well. How about you?
Very good, thank you. Yep, it's been great so far.
Yep.
Been a great conference.
It really has.
You guys did a lot of work for the summit, that's for sure. See if most people went home to take a nap after this or something. We'll see.
Yeah, they may have.
We'll get started in a few minutes, right, Odalise?
Yes, we'll give it a couple more minutes
Perfect. Thanks.
and then we'll get started. Yep. Okay, it's 2 o'clock, so we're going to go ahead and get started. If we have others to join, we'll allow them to join when they come in. But I want to welcome everyone to the 2021 Intermountain Tribal and Rural Opioid Wellness Summit Breakout Session. This session is titled Naloxone Education and Training Saving Lives, and it's presented by Timothy Keady, MS from Utah State University Extension. I'm your session moderator, Odalise Dial, and I'm available in the chat box at any time during the presentation. Before we get started, I do have a few brief housekeeping reminders. This breakout session, like the other sessions of the summit, is being recorded, and some content may be reproduced or broadcasted at a later time. If for any reason you wish to remain anonymous during the recording, please take the following actions. Click the 3 dots in the upper right corner of your participant panel. Choose Change Profile Name and edit your name. And I'll put this in the chat for you. Make sure your video is off by clicking the video icon in the bottom left corner of your screen. If your video is off, there will be a red diagonal line through the icon. And I'm going to put that in the chat for you right now, if anybody needs that information. If you need assistance with this process, you can message me directly in the chat box by opening the drop-down list and typing Odalise Dial. This will send me a private message. To ask a question, please either use the raise hand function, which is found in the participant panel, or type your question in the chat box. All participants will be automatically muted throughout the presentation, but I can turn your mic on if you have a question. Now I'd like to introduce our featured guest for this breakout session, Tim Keady. Tim is a member of the USU Extension initiative called HEART. The HEART, which stands for Health Extension, Assessment, Research, and Teaching Initiative Team, was created to help battle the opioid crisis in Utah. The team focuses on stigma and harm reduction, prevention and education, strengthening community ties, and resilience building. The HEART team was created with the assistance of Dr. Sandra Sulzer, USU Assistant Professor and Director of the Office of Health Equity and Community Engagement, or OHECE in Salt Lake City. The OHECE is an office of community engagement of professionals and health volunteers coordinating tribal, rural, and other wellness outreach initiatives. Tim is proud to be a contributing team member of the office. As a faculty member of USU Extension, Tim uses his unique knowledge, skills, and abilities to help increase the well-being of the population of Cache and Box Elder counties and all of Utah. Tim provides experience in chronic disorders education and management, including substance misuse and suicide prevention, critical incident management and response, public health, emergency medical services, mental and physical health counseling, bias and stigma awareness, risk reduction, promoting positive adult and youth behaviors, and harm reduction. His goal is to create a healthier Utah. Tim, thank you for joining us.
Thank you very much, Odalise. Appreciate that. As you can tell, I've done a few things, so hopefully I have some good things to share with you regarding naloxone, how we work with that and how that works in our communities to make a safer community for those who may have a need for that. As we begin this process, this is just the agenda that we will go through. I appreciate you being here, and I appreciate the chance to provide these trainings to those that need it. As we begin, I mentioned, as I did last time, this information was created with the assistance of Michelle Chapus, as well as Aaron Madden, also Dr. Aaron Madden. So we've got people who have helped us with this. So we've used these for a little while. I think they've worked pretty well. We kind of make them our own as we do them a little differently, but we appreciate the information that's here, and we hope to share it with you in a way that works and has you learn some good information. As you can tell, we're going to do some surveys, just like we always have. We're asking you to do this pre-training survey, if you would. Give you approximately 2 minutes to do that. Hopefully it will go relatively smoothly. I know Odalise is going to put that in the chat, I believe, so it works, as most people cannot click on it on their sites. And as all of you are getting that done, we'll just begin, knowing that your answers will be confidential. I'd just like you to answer those as we begin, so we can see how we can increase your understanding of this important topic, and possibly make this training a better training as we go forward. Okay. As we begin this process, we want to talk about opioids. One of the things we're working on here is defining what an opioid actually is. Opioids are a class of drugs that are commonly used to relieve pain, but also include some illicit drugs. You'll see some lists here with prescription painkillers, the oxys, Vicodins, even tramadol, codeine, Tylenol-3 with codeine, and also some illicit drugs, the heroin, the opium, fentanyl-laced drugs, which are really something that we're finding to be a big issue across the state, across the nation, actually across the world. Fentanyl-laced drugs, obviously, all different types of things are being found with fentanyl in them. We've read some different information. In Arizona, for example, 5 years ago, they found 0 pills that contained fentanyl. And 5 years later, they found 6 million pills laced with fentanyl, basically made into a pill that's more likely to be taken by people who are used to taking pills. So we're finding lots of issues when we're talking about opioids. Obviously, combination, poly-use of different drugs makes it more difficult to be able to respond appropriately to these medications and drugs. But we know that it's important for us to understand what we're doing when we're looking at someone with possibly an overdose. So we talked a little bit about opioids are an agonist. So it's a substance which initiates a physiological response when combined with a receptor. You'll find out more about that in a minute. They cause respiratory depression. So when they reach the receptors, opioids have an effect that's similar to that of morphine. And morphine's effect may increase feelings of pleasure, warm relaxation, and reduce pain. It's often abused for that purpose, obviously to feel pleasure and relaxation. Fentanyl-laced drugs are causing difficulties across EMS, law enforcement, fire, and first responders. So there are issues that we're all seeing on a regular basis, at least in first responders. What's naloxone's relationship to opioids? Naloxone is not an opioid, but it's an opioid antagonist. An antagonist is a substance that interferes with or inhibits the physiological action of another. So naloxone is a medication that reverses the effects of opioids. It only works on opioids. So if someone's overdosing due to alcohol, benzodiazepines, meth, stimulants like cocaine, it will not work. However, if someone's used those medications or drugs unknowingly and had opioids in those, you can still try and use naloxone. Naloxone will not have a negative effect on almost any person who uses it. Somewhere around 99.99% will have no side effects from naloxone. So it's a very good medication, it's been used for many years. We're going to talk a little about how it actually works. We're talking about opioid receptors on the brain. These are the receptors, you can see them marked off here. This object is actually representing an opioid attaching to the receptors on the brain. So during an overdose, the opioids bond to the opioid receptors in the brain and cause the breathing to slow and possibly to stop. And that's our big concern with opioids. So as you go to the next slide, you'll see naloxone represented in kind of these rectangular objects, pushing off or replacing the opioid on the receptors of the brain. So we say that naloxone has a stronger affinity to opioid receptors. So it kicks off the opioids from the receptors for approximately 30 to 90 minutes, allowing a person to breathe again. So that's a pretty big deal if we can have that change occur in a person who's having an overdose. And again, no matter if they have something else on board, so they have alcohol, benzodiazepines, whatever it may be in their system, what we're really concerned about when we're talking about breathing is the addition of opioids. So naloxone will take care of that and provide us some time at least to get that person some more care. So naloxone comes in different forms. You'll see here, it's a nasal atomizer. So naloxone hydrochloride that can be injected up the nose, so nasally. Then we have Narcan nasal spray, which actually, instead of having to assemble something like this, we have on this side with a syringe and an atomizer on the top. We actually have a spray that actually can just be taken out of its blister pack and used the way it is. So obviously that's a little bit easier. We have an auto injector. The FZO auto injector is used, kind of like an EpiPen. It kind of walks you through it and tells you how to use it. It can be injected into a large muscle group. And then we have the Narcan here, but new Flexado, I don't know who thought of that name. It's kind of an amazing name. Flexado nasal spray, which instead of having the 4 milligrams, which is in the Narcan currently, 4 milligrams of naloxone, this nasal spray contains 8 milligrams of naloxone, partially due because of the increase in synthetic opioids that are found out in the community. So we've got the Flexado that contains twice as much naloxone as the current nasal spray that's out there with Narcan. So we want to keep, it's a great idea to have that. It's just amazing that we have actually had to change some of the things that we're providing for community members, as well as EMS and fire, to use in the field due to the amount of drugs we're finding on the street that contain fentanyl, high doses of synthetic opioids. So what's naloxone? Again, Generic naloxone may come in a pre-filled syringe, small bottle that you actually fill. It can be used one of two ways, intramuscularly or with the atomizer that we have down here. We talked about that before. Naloxone kits in most cases contain 2 vials or 2 nasal sprays, because we are concerned that that first spray or injection may not be enough based on what that person has ingested or injected. So why do we need naloxone training? Obviously, there's a huge increase in fentanyl overdose across the states and across Utah. There's even health alerts that came out on December 17th, 2020. There's a CDC health alert network information page that came out. I have one here actually, if we can see it. A little bit difficult, but just as an example, it's a health alert network released health alert number 438. Increase in fatal drug overdoses across the United States, driven by synthetic opioids before and during the COVID-19 pandemic. And some of the numbers that they have talked about significant increases up to May 2020, and you'll see it's even gone higher since then. So we should probably mention that this is obviously part of a harm reduction method of reducing deaths from opioids. So when we talk about harm reduction, this can be included in that naloxone training as part of that. So we're using and we're worried about this across the nation due to the deaths from prescription and non-prescription opioids. This was till 2019. We thought we actually had some drop in Utah. We found the deaths actually were dropping here. It's still increasing across the states, but we found it was dropping. So we were excited about that. So we're very good in some areas in Utah. Things like, tobacco use, we're generally on the lower side. But opioids, we've been in the top 10 for probably almost 20 years now. So the graph shows data from the Center for Disease Control on deaths due to opioids, including prescription opioids like Oxy and Percocet, and then illicit drugs like heroin. So we had thought that the rates were coming down since about 2016, but we're finding that's not actually true as we've gone forward and looked at those new numbers that we're seeing now. This is just a provisional drug overdose death count that talks or actually shows you approximately 91,862 predicted deaths for a year up until May 2021. Those numbers were still being counted, and every time I look back, they've gotten a little bit higher. So percent change in the United States, approximately 30%. So we're not saying that it was all due to COVID-19, but obviously that was an impact that I saw in the clinics I work with and the people that we work with across the state and across the nation. So approximately 30% increase, and approximately 70% of those deaths involved opioids, and 73% of those involved synthetic opioids, so fentanyl, etc. So we're worried about the increase in fatal drug overdoses across the United States being driven by synthetic opioids. We're seeing that before and during the pandemic. It's just an example of some of the issues that we're seeing, even with reduced visits to a hospital. So we're talking about suspected non-fatal overdose numbers for 42 states that were provided to us on some data that we looked for from the CDC. Then you'll see all drugs up on the top in blue. And you'll see that even as the number of total ED visits dipped, the number of overdoses still remained very high and actually increased, and actually still is increasing again across the nation. So this is for stimulants, this is heroin, and the issues that we have with some of these numbers, hearing people speak from the CDC as well as law enforcement, was that even during all the pandemic issues and where they thought they would see less at some point, nothing really changed with the stimulants and heroin. I mean, it actually did become worse for the synthetics. So a big problem for us across the nation. And with somewhere around that 91,000 people dying from an overdose, becomes very alarming for many of us, and all of us actually, that do this work, and others that don't. So if we talk just briefly about some of the risk factors for an opioid overdose. We talk about opioid overdoses can happen to anyone who ingests enough of an opioid. Some factors make people more likely to overdose, such as taking other medications that slow your central nervous system. So antidepressants, benzos, Xanax, Prozac, drinking alcohol, which we know many people do both or more, so poly use of drugs. Taking opioids again after having a break from them, or if they've gone to jail, went through treatment. Being elderly, over 65, that's something that we don't often think about when we think of overdose from opioids or other drugs. But many people make mistakes as they get older. We just listened to someone speak about people dying of suicide in the ages, 50 to 60 years old. So we do know that being elderly can be a risk factor just because of making mistakes, because of possibly being unable to make good decisions on their own. And having been in EMS, we did respond to people who actually by mistake took too many opioids and caused an overdose. And they were given opioids by one of their sons, and it became a problem for them. As we respond, we would find that someone would tell us, we think they're on these medications, we're not sure. Then you find out that a son or daughter, while trying to help their elderly parent who was in pain, gave them some of their medication, which obviously is illegal, but also causes significant problems because that person doesn't understand how to use that medication correctly, and the dosage may be off. So we encourage people not to do that. But just I have this in here just because I think it's important to remember it's not just someone who's young on the street using a drug to get high. It can be someone who's older that just makes an error with that opioid. So people with high overdose prescriptions, with high dose prescriptions for opioid painkillers are more likely to have an overdose. People with opioid addictions, obviously, or other substance use disorders. Then the COVID-19 impact, that caused problems with people I worked with across the board. Loneliness, stress, lack of resources, put them at greater risk. One of the things we looked at really quickly, National EMS Services Information System showed a nationwide uptick in both the amount of opioid-related 911 calls and naloxone distributed by first responders. And in May of last year, the number of incidents that required naloxone spiked, hitting a 3-year peak at roughly 7,000 per week across the nation. So think of that, 7,000 people were revived with naloxone per week in just May of last year. So American first responders are still using and administering naloxone at rates not seen in many years. So addressing risk factors for overdose among people with opioid use disorders. We talked a little bit about harm reduction, but it's an approach that's very effective for addressing addiction and overdose. And the definition of harm reduction is practical strategies aimed at reducing negative consequences associated with drug use. Again, such as avoiding death or getting a disease like HIV. Goal of harm reduction is meet people where they're at, not necessarily stop them from using drugs altogether, because we hope that they will make that choice on their own. If not, we hope to get them thinking along those lines. Stages of change, all the way from pre-contemplation to completion. To reduce bias and stigma, we also talk about reducing people's affinity to use and not use drugs, and words make a difference. We talk about person-first language, gain knowledge about what's a substance use disorder, what that person is going through. Remember that substance use disorder is a chronic medical condition. Just as someone taking insulin for diabetes, someone on medication for their substance use disorder, is being treated appropriately by their physician. So we want people to realize that the difference in harm reduction is embracing that broader use and idea of goals and successes related to addressing substance use. So allowing them to use is not something we want them to do or encourage, but the reality is we do want them to have the opportunity to be alive and consider treatment, at least in the US. There's some changes across the world, and we hope to get there at some point, but we're not there quite yet. So to reduce bias and stigma, I'd like you to think of how you use your terms. Substance use disorder is a chronic medical condition, and then use some of these terms if you will. Addict, user, or junkie, would rather have you call that person a person with a substance use disorder or a person who uses substances. Clean or sober, not really great terms. We want to use drug-free. Dope sick, someone who's going through withdrawals. We talk about suffering from withdrawal. Drug, you want to call it a medication or non-medically used psychoactive substance. Again, change your terminology so someone is not the term that you're using. A reformed addict is a person in recovery, and that's probably enough to start with. So using those terms if you can will help reduce stigma. I encourage people in treatment or even people in long-term recovery to use those terms. And sometimes it's hard for them to change, but as they start doing it, they do notice a difference in people responding to them and how they feel about themselves. So that becomes important. Okay, harm reduction, myth versus fact. We give out naloxone, more people use drugs, and have Narcan parties, or they'll overdose and revive each other. Okay, obviously it doesn't happen. There's no evidence from scientific studies. The harm reduction approaches like naloxone increases addiction or risky drug use. Having seen people revive, it's not something you want to do. Believe me, it's not something they want to do. And if any of you have been on any medications, especially an opioid, and had to stop that opioid medication, especially if you weren't tapered off correctly by a physician or used for a long term and you stopped using that opioid, it's not a lot of fun. You're sick, you don't feel well, you can't sleep. You can have your legs shake, sweating profusely, whatever may happen to you from that. Basically, you are addicted to a substance, which is an opioid, that causes a physiological response when you stop it. So you got to be very careful that we don't think that people are doing it on purpose. It doesn't happen. And anybody will tell you that's been revived, especially by Narcan, it's not something fun for them to do. I'll go back just for a second. Say that in fact, people who are trained to use naloxone are more likely to know how to reduce their risk for overdose, are much less likely to die from an overdose, and are slightly more likely to enroll in a treatment program than people who did not get naloxone training. So that little bit of training is like training someone in CPR. They're more likely to respond to emergency by making a phone call than other people who have not been trained. So again, training helps no matter what we're talking about. Okay, harm reduction myth versus fact number 2. If we give naloxone in our community, more people will become addicted to drugs and more people will overdose. Again, no. Research shows that addiction and overdose rates do not increase when naloxone is given out. Some patients with severe addictions may experience more overdoses than they otherwise would have simply because the naloxone kept them alive instead of previous overdoses becoming fatal. So people are alive, that means they may overdose again, right? Just like anyone else. If you're alive, things can happen. We have first responders who used to say it's not something we want to do. Let's go back and have to do it again. Well, we've seen people who've been revived numerous times that after, I've actually worked with patients who after the 3rd time decided they were done, that was enough. They'd been revived 3 times. We don't know how many other things had happened to them in between, but they decided to get treatment after that because they said they knew eventually they would die. So that person did get treatment. We know that responding to emergency helps anyone, especially in this case, if we have the knowledge, we have provided naloxone and Narcan to people in our community, and they've saved many lives just where I am. just the people that I've worked with in treatment and some of the naloxone that I've provided, we've saved many lives here. And that's something that's pretty amazing to have that feeling when someone comes in and say, hey, I was able to save someone because of the training that we received and because of the naloxone that we had and carried with us. There was a gentleman, we trained someone actually, we had a training in a facility, and the next weekend, a person came and said, hey, something great happened. And I said, what's going on? And they said, well, we got some great news. And someone had revived another person. He didn't know them. And he went to a party. Obviously, people were using drugs. He went to a party and saw someone unconscious, remembered his training, took out his naloxone and said, hey, I'll try and help. And helped that person, went through the process of giving them naloxone. And the person was revived and was able to get care after that to help them recover. And the person who did that was so amazed. And some of the comments that we received afterwards from people in his group and some of his counselors were, we saved 2 lives that day. So if you save 2 lives that day, that's a pretty amazing process. They were concerned that the person would not make it, that had actually revived the other because just having a difficult time, it's difficult to be in treatment. But after that, that person was so excited and so happy to be doing it. Said he's not just a dumb addict. He wasn't worthless. He could help others and he could be successful and save a life. And that was pretty amazing to him and pretty amazing to all of us. So we do want people to learn and know that saving a life becomes very important to anyone in many ways we may not recognize. When I first started doing that, having been in EMS for many years, I didn't expect that to be a big deal. I was like, yeah, well, it's not a big deal. Save somebody's life, right? Person's okay. We're happy for that person. Well, someone in the community, it's not their position. Now, if their training is, it really changes their life. I can say, I remember every person that I did not save. And I remember every person that I did save. So it really becomes interesting that in our community, we can do that ourselves and help others have that feeling of success, whether it's CPR, whether it's reviving someone who's choking. We want this training to become something that everyone does and everyone learns, just like that CPR training. Naloxone training should be everywhere. Everyone should carry that with them or have it available to them. Okay. Building your overdose response skill set. We'll talk a little more about that. One of the things we do need you to know is how to identify an overdose. Some of the symptoms, so signs and symptoms are pinpoint pupils, unconsciousness, not breathing or infrequent breathing, or someone who's got cold, clammy skin, or can have cyanosis, so some blue around the nails and the lips. That can be indications there may be an overdose. And we talk about doing a sternum rub for responsiveness, which just involves taking a fist and going very hard against the center of your chest. And if someone is unconscious and it does not revive them, we know we have a significant problem. And if we know that they may have used drugs or may have used something, or you see something around them that indicates some kind of activity, then we may want to think that we could use naloxone to help that person. So an overdose with an opioid causes sedation, sleepiness, low blood pressure, slowed heart rate, slowed breathing, pinpoint pupils. And that's where the black centers of the eyes become smaller than normal. Those are common. But remember, sometimes other medications can negate that. So we got to be careful that that's not just the first thing we use. The serious risk is that the patient's going to stop breathing. If they stop breathing, it's a problem. So we talk about using some other methods, rescue breathing, that type of thing also in just a moment. We'll show you some examples and give you some indications of how that works. So we're just going to show some injectable naloxone video, just with only instructions for you to watch for just a moment.
Hi, I'm Allison, a pharmacist, and today I'd like to go over how to use your naloxone product. It can be really difficult in an emergency situation to remember everything that you may have learned about naloxone. So feel free to come back to this video from time to time to review the information here so that you can always be prepared in
Kim,
the
we
event
can't
that
see
you
the
witness
video.
an opioid overdose. So you've called 911 and grabbed your naloxone. Now what? Injectable naloxone comes in a 1 milliliter single dose vial, similar to this one, and it can be given intramuscularly in the patient's deltoid on their upper arm, their quadriceps on the outer aspect of their thigh, or their
Kim, we
gluteal
can't see the
muscle on
video.
the upper portion of their backside. To prepare a dose, we'll first remove the plastic cap from the vial and grab the
Okay.
needle insert.
Maybe we'll stop that then. Let's see, are you still seeing the steps for responding to an overdose?
Yes.
Okay. So let's open this back up again. I apologize. So we'll just talk about that verbally and talk about how that works. We've got that in some other areas. So just so you know, when you get a chance, you'll actually get this to look at yourself. You can actually go and look at those on your own. But some of the steps that we talk about for responding to an overdose. Do you see my screen now? Hopefully.
Yes, we can see the steps for responding.
Okay, very good. So obviously we call 911. Even if you have naloxone. Talk about performing rescue breathing. That's 1 breath every 5 seconds. And preparing your naloxone to give to the person who's overdosing. There's no breathing or breathing is very shallow. Continue to perform rescue breathing until you're ready to give that or someone is going to give that to them. And then give that to the person. So we talk about giving that naloxone as soon as possible. Checking, doing the head tilt chin lift kind of thing. Remember from CPR, just to make sure their airway's not blocked or really crunched up somehow. Putting that nasal spray in their nose or injecting it, as she talked about, in the deltoids or other aspects of the thigh. If there's no change in 2 to 5 minutes, we talk about 2 to 3 minutes usually. Administer another dose of naloxone and continue to breathe for them. If you leave the person for even only a minute, put them in a recovery position. I'll show what that is in just a second, but just real quickly, some of the steps again, try to wake the person up. Wake up, wake up. Call 911. Someone's overdosed, someone's not breathing. Administer your naloxone, whether it's injectable or nasal, whichever it may be. Check for breathing again, see if they can breathe. If not, use those rescue breaths. And then if you do have to leave them, we talk about putting the person in the recovery position. When we're talking about checking for breathing and seeing if they're recovering from this or reviving from their overdose, let's talk about making sure you're checking them. You're using that sternum rub. You're talking to them. You're trying to wake them up, calling them by name if you know their name, saying, hey, wake up, whatever you can. Not shaking them violently, not throwing them in a shower, anything like that, but doing things that are appropriate for the time you're doing it. So if you're out somewhere where it's safe, you can do these things. Keep talking to them. Say, hey, can you get up, wake up? We're trying to help you. What can we do? Wait that 2 to 3 minutes. Again, 2 to 3 minutes in the event of an emergency seems like an eternity. So if you have someone there, ask them to time it for you. Because I guarantee if you've been through an emergency, that 2 to 3 minutes feels like a lifetime. So you want to try and do what you can. And if they don't come around, use that second vial of naloxone. Use that, see if you can get that person to come back, especially with a lot of we talk about synthetic opioids being out in the community. We want to see if we can stop that. So it takes possibly 2, 4 of the current naloxones that people have been using in EMS to revive someone. So we're talking about things that may take a little bit longer than we expect, but at least you're giving that person a chance by doing rescue breathing, making sure that they have some air in their system, gives them a chance for survival until 911 can activate the emergency medical systems. So when we're doing nasal spray, 1 up each nostril, one side, wait that 2 to 3 minutes. The second one, if necessary, up the other nostril. and doing it continually like that if possible, if you have more than 2 available. Talk about injecting naloxone into a muscle. We're doing injectable, so the muscle, thigh, butt, upper arm, and then seeing what happens in 2 to 3 minutes. Like I said, it will seem like a lifetime, but it's well worth that wait. Recovery position is what it looks like again. Remember not to make the airway at a different angle, trying to keep it as straight as possible. And also taking care of yourself, make sure you're not stepping on anything, not doing anything to cause damage to the other person, and not trying to hurt them or yourself. One of the things we get asked quite a bit is, will I get in trouble for calling for help when someone's having an overdose? In Utah, at least, there's Good Samaritan laws. It does protect people that call 911, provides immunity from arrest or prosecution for a drug possession when they call 911. But it does not protect people who report opioid overdoses from probation or parole violations. I've actually had patients come up to me and said, hey, you talked about Good Samaritan laws. What happened? How come I got arrested? Not sure why I was arrested. I helped somebody, did a great job. I said, that's great. Congratulations. You did that. But he says, well, I was curious why I got taken in. And then I'd ask, what else occurred? He said, well, I did have some other prior things that needed to be addressed in court. And I said, okay. Because I've heard other people tell me that they responded to emergency, were able to help assist someone in reviving them from an overdose. And the police officers didn't even ask a question as to who they were. They just thanked them very much for their help, told them how proud they were of them, and the person walked away. So again, it depends on where you are, what happens exactly, what the background may be. But we do have a Good Samaritan law, and we hope that that can continue to progress and allow people to help others who need it. Having been in EMS for many years and running an agency where we're at a university and they used to throw people out of their cars when someone was overdosing. They'd throw the person out of their car and drive away because they didn't want to get in trouble with the university or the local police officers. So I've seen lots of things happen that really were not very helpful for the patient and for our communities. So I'm hoping that we continue to progress with our Good Samaritan laws. Briefly, we'll talk about where can you get naloxone. Naloxone is available from most pharmacies. It's provided to people under Utah statewide standing order. So no individual prescriptions are needed, but you may have to pay. So Intermountain Health Services, tribal healthcare facilities, the pharmacies, commercial pharmacies, some people will pay a copay. Others people will be charged a full amount, up to $137 for naloxone kit, for example. So being careful where you go and talking to people before you try and get it can be very important. We're trying to get prescriptions of naloxone to be done for free. So it'd be filled for free, I should say, but we'll see what happens with that going forward. Utah Naloxone provides some training as well as, or I should say provides great training as well as naloxone for people that take their training courses. So they're a great resource. Department of Health also, if they do have naloxone, they will also provide it for free. So both of these will provide it for free to you. Utah Naloxone is generally injectable. Department of Health is generally Narcan or a nasal spray. So many states, we have people here from other states. There's actually people here from across the nation. There's standing orders for naloxone is available for most states. And also some things recently came out that they're going to include naloxone when they prescribe opioids for high-risk patients. So there are things changing. We're trying to make sure that happens on a regular basis. So if someone is prescribed an opioid for a reason, they're offered or given a prescription for naloxone, which they don't even need, but allows them to go get it, maybe covered by their insurance. So the idea behind the standing order is to increase the access to naloxone for those who might be at risk of an overdose or who might be in a position to assist someone at risk for that overdose. So pretty important stuff for our states and counties to be doing. The important naloxone facts to remember: naloxone is safe and has no major side effects for, again, 99.9% of the population. Naloxone will bring a person back into active opioid withdrawal, which may mean vomiting, irritability. The symptoms are not fatal. Naloxone works for 30 to 90 minutes. Some opioids last longer, or synthetics especially, so people can re-overdose. Always call 911 after an overdose and after the use of any naloxone or Narcan. I also want to mention, when you do attempt to revive someone or able to revive them, we want you to have someone around them that they know. If you can do it that way, that's really great. Sometimes people will respond and stand up, or just say, hey, I got to get out of here. But I tell people, think of being woken up from even just a nap. Someone comes in and wakes you up from a nap, and you're startled, you wake up, you don't know where you are, you're not sure of the situation. That's pretty common to have that response. Now, multiply that times like 100, and someone has just been in an opioid overdose. They're given naloxone, and they're basically stopped in just a second, and they're instantly alert. Well, they're not really alert, they're just waking up kind of, and they're like, oh my gosh, what's going on? What happened? They don't really understand what's occurring, obviously. So a big problem, plus the physiological aspect of that withdrawal. So having someone that they know, that they can talk to, if it's available, if someone's available, is really a great way to do it. We encourage that with our patients, to try and have somebody around that they know if you have to revive someone. Not always possible, but try and do it. Having police officers standing above you, or people in uniforms like even me with EMS, standing above them in uniform with all kinds of stuff in our hands, we're doing all kinds of weird stuff to these people, I would be freaked out too. So it's not something I don't expect, but it's not everyone that has that response. It's only a few people that respond in a way where they really just want to get up and, please let me get away. Most people are really pretty good. They'll stay there, and if you have someone that they know talking to them, we try and make them more comfortable. So it's something to think about as we're doing that. Encouraging people to do things that are going to help our patients feel better about what just happened in any case. Okay, so the important naloxone facts to remember: naloxone is not an opioid. It reverses the effects of opioids, only works on opioids. It's a safe medication used since approximately 1971 in hospitals. I used it many years ago, even in EMS, when we did our turns in the hospital. So I've been doing it for a long time. I've actually seen it used, and I've seen people injected with enormous amounts of naloxone with no side effects. So we know it's actually a good medication. And finally, naloxone saves lives. It's actually a great medication. It's a great thing to have. We want everyone to understand it and get it if they want it. We want to carry it and use it. And if you work in the field with substance use disorders in any way, or have people that you are concerned about in your own lives, we encourage you to get trained and find and get naloxone. Come and talk to me, come and talk to whoever in your community, see if there's some available, and we'll get that to you somehow, or you release the information to get it. Okay, just really quick, any discussions that I've missed with Elise? Any questions anyone has? We have just a few moments. We actually finished almost on time. I think there may not be any questions, as we can tell. Well, we appreciate you, and we're going to have you fill out one more training survey. There we go. Elise is there. If you put that in the chat also, the training survey, tell us how we did, how I did. Again, answer the questions best of your ability. Answer they're confidential. Was there anything in the chat, any questions anyone had?
No, there were no questions.
Good. Just as the second day we've done it, hopefully you guys have gotten some good information. We encourage you to help us be better at what we do by doing the survey. And I appreciate your time. we value this. Appreciate Michelle doing this for her patients and for her clients and what she does and what she did for us. For Dr. Sulzer for creating my position even, as well as Susie Sulzer and all she does and all the crew from their office. We appreciate what they do and how they keep us on track, and for the great work they do and for the lives that are saved by what happens here. So here's some of the references. This will be available to you. Obviously our moniker there, and then some of the contacts also, Dr. Sulzer and Susie, as well as myself if you have any questions or concerns. So I thank you all very much. I appreciate your time. And please let me know if we can do anything to help you going forward.
And thank you, Tim, for sharing your expertise with us today. We appreciate you taking the time to be part of the 2021 Intermountain Tribal and Rural Opioid Wellness Summit. And we appreciate everyone for joining the Naloxone Education and Training Saving Lives breakout session, which is brought to you today by the Utah Department of Human Services Division of Substance Abuse and Mental Health, the Rural Health Association of Utah, Utah State University, USU Emma Eccles Jones College of Education and Human Services Department of Kinesiology and Health Sciences, USU College of Humanities and Social Sciences, USU Extension, and SAMHSA. As a reminder, the main room is available for any general summit questions or help getting into your next session. Tomorrow, our main sessions feature a live episode of the Debunked podcast, a panel discussion focused on mental health, incarceration, and recovery, a special presentation titled Gender Equity Etiquette, the announcement of our Goose Chase Scavenger Hunt winners, and closing remarks by Utah State University's Extension Vice President, Dr. Ken White. Make sure to log into the webinar before 9 a.m. so you don't miss a thing. Thanks again for participating in the 2021 Intermountain Tribal and Rural Wellness Summit, and we'll see you tomorrow.
Thank you all again. Take care. Have a great night. Thank you, Odalise.
Thanks.